Welcome, everyone, and thank you for joining us today. We are excited to share an important topic in primary care: abnormal uterine bleeding, or AUB. This is a condition commonly faced by many patients, and it is vital for primary care providers to be well equipped to recognize, assess, and manage it effectively. Let's get started. Outline: definition and classification, pathophysiology, approach to diagnosis and investigation, principle of management, treatment. Case scenario: Lady A. A 39-year-old woman presents with heavy menstrual flow and increasing tiredness over the past 3 months. Is she having abnormal uterine bleeding? What is the definition and classification of abnormal uterine bleeding? Abnormal uterine bleeding refers to irregularities in the menstrual cycle involving frequency, regularity, duration, or volume of flow outside of pregnancy. It affects up to one-third of women, commonly during menarche and perimenopause. A normal cycle occurs every 24 to 38 days, lasts 2 to 7 days, with 5 to 80 milliliters of blood loss. The normal menstrual cycle consists of two main components: the ovarian cycle and the endometrial cycle. In the ovarian cycle, the follicular phase begins with follicle development, stimulated by FSH, leading to estrogen production. Mid-cycle, a surge in LH triggers ovulation, marking the transition to the luteal phase. The luteal phase is always fixed at 14 days, during which progesterone becomes dominant to support potential implantation. In an ovulatory cycle, ovulation occurs, and both the ovarian and endometrial phases proceed normally. However, in a non-ovulatory cycle, ovulation does not occur, resulting in irregular hormonal patterns and often an uncoordinated endometrial cycle. In the endometrial cycle, the uterine lining undergoes cyclical changes. During the proliferative phase, driven by estrogen, the endometrium thickens. In the secretory phase, influenced by progesterone, the lining becomes more vascular and glandular, preparing for implantation. If fertilization doesn't occur, hormone levels drop, leading to menstruation and the shedding of the uterine lining. These synchronized cycles are essential for reproduction and maintaining hormonal balance. Understanding the distinction between ovulatory and non-ovulatory cycles is crucial for diagnosing irregularities like abnormal uterine bleeding. The pathophysiology of abnormal uterine bleeding involves several key mechanisms. First, ovulatory disorders, such as anovulation, lead to hormonal imbalances and disrupt the regular menstrual cycle. Second, there may be a disruption of the hypothalamus pituitary ovarian HPO axis, which plays a critical role in regulating ovulation and menstrual cycle dynamics. Lastly, abnormal derangements of the uterus, including structural issues like polyps, fibroids, adenomyosis, or malignancy, can also contribute to abnormal uterine bleeding. You want to proceed with history taking from Lady A. Is there a system you know of that can help you take relevant history from the patient? The International Federation of Gynecology and Obstetrics, or FIGO, provides two standardized systems for assessing and classifying abnormal uterine bleeding in reproductive-aged women and girls. FIGO System 1 defines bleeding patterns using four key descriptors: frequency, the interval between menstrual cycles; duration, the length of the menstrual bleeding; regularity, the variation in cycle lengths; flow volume, the perceived amount of blood loss. FIGO System 2 categorizes potential causes of abnormal uterine bleeding using the acronym POEN. POM represents structural causes: polyp, adenomyosis, leiomyoma, and malignancy or hyperplasia. COEN covers non-structural causes: coagulopathy, ovulatory dysfunction, endometrial issues, iatrogenic causes, and not yet classified. These systems provide a comprehensive framework for evaluating and managing AUB effectively. FIGO System 1 describes abnormal uterine bleeding patterns using four key parameters. Frequency. Normal cycles occur between 24 to 38 days. Cycles longer than 38 days are classified as infrequent, and those shorter than 24 days are considered frequent. Duration. The normal duration of menstrual bleeding is 8 days or less. Bleeding that exceeds 8 days is categorized as prolonged. Regularity. A normal cycle is considered regular when the variation between the shortest and longest cycles is within 7 to 9 days. If the variation is 10 days or more, it is classified as irregular. Flow volume. Flow volume is subjectively determined by the patient as light, normal, or heavy. Intermenstrual bleeding, IMB. This refers to bleeding that occurs between otherwise regular menstrual cycles. It can be random or cyclic, occurring in the early, mid, or late cycle. Unscheduled bleeding on progestin, estrogen gonadal steroids. Bleeding can occur in individuals using hormonal medications, such as birth control pills, patches, or injections. This may present as unscheduled bleeding. The FIGO System 2 classifies abnormal uterine bleeding into structural causes, represented by PALM, polyp, adenomyosis, leiomyoma, and malignancy or hyperplasia, and non-structural causes, represented by COIN, coagulopathy, ovulatory dysfunction, endometrial issues, iatrogenic causes, and not otherwise classified. AUBP, or polyps, involves benign overgrowths in the uterus or cervix, often causing bleeding between periods. Risk factors include obesity, advanced age, and tamoxifen use. Diagnosis is through ultrasound or hysteroscopy, and prevention includes oral contraception or a levonorgestrel IUD. AUBA, or adenomyosis, is a benign uterine condition where endometrial glands invade the myometrium, causing heavy bleeding, painful menses, and pelvic pain. Risk factors include multiparity and prior uterine surgery. AUBL, or leiomyoma, involves benign uterine fibroids classified by location, such as subserosal or intramural. Symptoms include heavy bleeding, pelvic pressure, and reproductive issues. Risk factors include parity, obesity, and hypertension. AUBM includes malignancy and hyperplasia involving the uterus, cervix, and endometrium. Risk factors include obesity, HPV, and hormonal medication. Symptoms range from heavy bleeding to intermenstrual and postmenopausal bleeding. AUBC, or coagulopathy, involves bleeding disorders like platelet dysfunction, von Willebrand disease, or coagulation factor deficiencies. It often presents as heavy menstrual bleeding since menarche with associated symptoms like bruising or frequent gum bleeding. AUB-O, or ovulatory disorders, includes hypothalamic, pituitary, and ovarian dysfunction, as well as PCOS. Causes range from genetic and endocrine issues to trauma, inflammation, and neoplasms. AUBE occurs when endometrial tissue grows outside the uterus, as seen in conditions like endometriosis. It disrupts the control of uterine bleeding through impaired contractility and platelet formation, leading to intermenstrual, irregular, or heavy bleeding. AUBI is iatrogenic, caused by medications like hormonal preparations, oral contraceptives, anticoagulants, chemotherapy, or dopamine-related drugs, such as antipsychotics and antidepressants, leading to intermenstrual, irregular, or heavy bleeding. AUBN refers to abnormal uterine bleeding from other causes, such as cervicitis, vaginitis, foreign bodies, or trauma. You have covered FIGO Systems 1 and 2. These will assist us in taking relevant history and performing examinations to arrive at our diagnosis. Approach to diagnosis. When taking a history, begin with menstrual history, focusing on the onset, frequency, duration, cyclic versus acyclic patterns, severity, amount of bleeding, last menstrual period, any associated pain, and changes in menstrual patterns. Note the age at menarche and assess for heavy menstrual bleeding, such as soaking pads within 1 to 2 hours, passing clots larger than 1 inch, or experiencing flooding or leaking. Next, include the medical history, checking for any family history of coagulopathy, easy bruising, or bleeding disorders. Record dates of pregnancies and assess for any reproductive tract diseases. When gathering history, include social history, such as marital status and number of partners. For family history, inquire about gynecological pathologies, coagulopathy disorders, or malignancies like cervical or uterine cancer. Next, explore the sexual history, focusing on dyspareunia, number of partners, any history of sexually transmitted illnesses, treatments received, and the frequency of sexual intercourse. Finally, review the drug history, including anticoagulants, hormonal medications, contraceptives, and antiplatelet therapies. Identify pathological effects, such as anemia, pelvic pain, and impaired quality of life. Next, address treatment expectations, including patient concerns and needs, future fertility and contraception wishes, and the need for definitive treatment when discussing alternatives. Examination consists of 3 key components. First, the general examination, where you assess for pallor, endocrinopathy, thyroid gland enlargement, palpable lymph nodes, coagulopathy, pregnancy, acne, obesity, hirsutism, and vital signs. Second, the abdominal examination, focusing on the liver, spleen, and any abdominal masses. Lastly, the pelvic examination, which includes inspection of the vagina and vulva, visualization and palpation of the cervix, and a bimanual internal examination to estimate uterine size and identify adnexal masses. A 39-year-old woman complains of heavy menstrual flow over the past 3 months. Her periods occur every 24 days. Day 1 is moderate, and days 2 to 4 are heavier. Due to the heavy flow, she has to use both tampons and sanitary towels, 6 to 8 per day. Her last menstrual period, LMP, was 2 weeks ago. There is no associated abdominal pain or constitutional symptoms, nor is there any intermenstrual or postcoital bleeding. Her last 2 consecutive pap smears, conducted over the past 2 years, were normal. She has had 2 deliveries and currently uses barrier methods for contraception. She is not keen on becoming pregnant. There is no significant past medical or family history. However, her present condition is causing distress as her social activities are restricted due to the abnormal bleeding. General, BMI, 35 kilograms per meter square meter. Pallor was noted. There was no facial acne, hirsutism, bruising, thyroid enlargement, or palpable lymph nodes. Vital signs were normal. Examinations. Both abdominal and pelvic examinations were normal. The pelvic examination revealed a healthy cervix and an anteverted, normal-sized uterus. No other pelvic masses were palpable. You can take a break and resume when ready. Up next, we will cover investigations, principles of management, red flags for referral. Stay tuned for more. Welcome back. What are the differential diagnoses for Lady A at this point? Use palm coing. How do you plan to investigate her? What investigations can be ordered to assist in evaluating AUB? The evaluation of abnormal uterine bleeding starts by excluding gravid status, typically using a urine pregnancy test, UPT, which is quick and commonly used. A beta-HCG blood test may be considered for higher sensitivity or unclear results. Next, confirm the uterine origin and chronic pattern through a detailed patient history and physical examination. Once confirmed, proceed to investigate structural causes under the palm group. This includes physical examination, transvaginal ultrasound, which is the first-line diagnostic tool for identifying structural abnormalities, hysteroscopy or hydrosonography for further evaluation if ultrasound findings are inconclusive, and endometrial biopsy if needed, especially for women at risk of endometrial hyperplasia or malignancy. If structural causes are excluded, consider non-structural etiologies under the CON group. To evaluate ovulatory disorders, AUBO, assess the history and bleeding patterns. For suspected PCOS, check testosterone levels as well as FSH and LH levels. A higher LH to FSH ratio can suggest PCOS. For iatrogenic causes, AUBI, review medications such as gonadal steroids, IUDs, and drugs interfering with dopamine and serotonin uptake. For coagulopathy, AUBC, conduct coagulation studies such as PT, PTT, and INR where available. Additional lab tests include a full blood count, FBC, to assess for anemia or infection, thyroid function tests, TFT, to rule out thyroid dysfunction, prolactin levels if prolactinoma or hyperprolactinemia is suspected, high vaginal swab, HVS, to screen for genital infections, a cervical smear to screen for malignancies or infections. If no specific cause is identified after comprehensive evaluation, the diagnosis of AUBN, not otherwise classified. Not all tests are required. The choice of investigations should be guided by the patient's history, physical examination, and the working diagnosis based on the Palm-Cohen classification. Pelvic ultrasound. Pelvic ultrasound is the first-line diagnostic tool for evaluating abnormal uterine bleeding. It is highly effective for detecting structural abnormalities such as uterine fibroids, polyps, and ovarian pathology. Transvaginal ultrasound provides better visualization of the endometrium and uterine cavity compared to transabdominal ultrasound. Hysteroscopy. Hysteroscopy is used to identify polyps and endometrial diseases, allowing direct visualization of the uterine cavity for accurate diagnosis. Endometrial thickness, ET. Measuring endometrial thickness is a key component of the evaluation. Biopsy is indicated if the endometrial thickness exceeds 4 millimeters in postmenopausal women, which raises concern for malignancy or hyperplasia, or 15 millimeters in premenopausal women, particularly when accompanied by abnormal bleeding. Endometrial biopsy. Endometrial biopsy can be performed either hysteroscopy directed or through blind global sampling using a Pipel device, providing further assessment of endometrial abnormalities. Investigations: urine pregnancy test, negative. Full blood count, FBC. Hemoglobin is 9.6 gram per DL, indicating anemia. Mean corpuscular hemoglobin, MCH, is 20 pg, and mean corpuscular volume, MCV, is 65 FeL, both below normal, suggesting microcytic hypochromic anemia. Total white blood cell, TWBC, count is 6, and platelets are 200, which are within normal ranges. Pelvic ultrasound. The uterus is normal in size, measuring 6.5 centimeters by 4.0 centimeters. Endometrial thickness is 5 millimeters, within the normal range. Both ovaries are imaged and show no evidence of polycystic ovarian syndrome. No adnexal masses are detected. Working diagnosis. The patient is suspected to have iron deficiency anemia secondary to AUBN. No structural abnormalities were detected on clinical or ultrasound examinations. Uterine fibroids or polyps, none visualized. Endometriosis, unlikely, as it is typically associated with pelvic pain and dysmenorrhea. Adenomyosis, unlikely, as menorrhagia with an enlarged tender uterus and dysmenorrhea are not present. Malignancy, unlikely, with no constitutional symptoms, a normal pap smear, and normal endometrial thickness, ET. PCOS, no clinical or ultrasonic evidence. Coagulopathy, unlikely, as there is no history of easy bruising, and her 2 deliveries were uneventful. What treatment options are available for this lady? Principles of management. First, establish whether the condition is chronic AUB, lasting more than 6 months, or acute AUB, which requires urgent intervention. The initial step should always be to exclude pregnancy. Understand the differential diagnosis of AUB based on the Palm-Cohen classification, acknowledging that women can be affected by more than one component. Most AUB cases result from a combination of coagulopathy, ovulatory, or endometrial dysfunction, which often do not require secondary referral. Treatment can be initiated and successfully managed in primary care. Referral to secondary care is recommended if malignancy is suspected, endometrial biopsy is required, or pathology is suspected. Uterine endometrial assessment using hysteroscopy with endometrial biopsy or ultrasound improves the detection rate of endometrial pathology, both malignant and benign. Treatment, non-hormonal treatment, mechanism of action. NSAIDs reduce prostaglandin levels by inhibiting the COX enzyme, leading to a 25 to 35% reduction in menstrual blood loss. Side effects, mild gastrointestinal upset. Example, tablet mefenamic acid 1 gram taken 4 times daily from day 1 to day 5 of the menstrual cycle. Non-hormonal treatment, antifibrinolytic agents. Mechanism of action, MOI. Antifibrinolytic agents work by causing a reversible blockade on plasminogen, resulting in up to a 50% reduction in menstrual blood loss. Example, tablet tranexamic acid 500 milligrams taken 3 times daily, TDS, from day 1 to day 5 of the menstrual cycle. Hormonal treatment, mechanism of action. Progestogens act as anti-estrogens by minimizing the effects of estrogen on target cells, maintaining the endometrium in a state of non-proliferation. Side effects. Common side effects include weight gain, headache, edema, and depression. Example, norethisterone, 5 to 15 milligrams daily. Medroxyprogesterone, 5 to 30 milligrams daily, either from day 5 to day 25 of the menstrual cycle or continuously. Other options include DMPA and Nexplanon. COCP, combined oral contraceptive pill. Mechanism of action, MOI. COCP promotes regular shedding of a thinner endometrium and inhibits ovulation, leading to a 50% reduction in blood loss. Side effects includes the risk of thromboembolism, weight gain, breakthrough bleeding, and abdominal discomfort. Hormonal treatment, levonorgestrel intrauterine system Mirena. Mechanism of action. The device releases a steady amount of levonorgestrel, 20 milligrams per 24 hours, from a steroid reservoir around its vertical stem, resulting in an 80% reduction in menstrual blood loss. Side effects includes intermenstrual bleeding and breast tenderness. Treatment options available for this lady. Mild anemia. Manage with daily iron supplements. Non-hormonal treatment. Administer tranexamic acid and NSAIDs during menstruation. Hormonal treatment. Options include COCP or the levonorgestrel intrauterine system, initiated for 3 to 6 months. The patient is prescribed daily iron supplements, along with tranexamic acid and NSAIDs during her menstrual cycles. Follow-up. Schedule a TCA in 3 months. Advise an immediate TCA if there is an increase in heavy bleeding or symptoms of anemia. Provide guidance on adopting a healthy lifestyle, including a balanced diet and weight loss. What are the indications for secondary care referral? The patient has been under your care for the past 6 months. However, there has been no improvement. What is the next step for her? Red flags indicating secondary care referral. 1. Suspected gynecological cancer with features such as postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding, pelvic mass, or a cervical lesion. 2. Endometrial biopsy required to rule out hyperplasia or malignancy in cases of persistent intermenstrual bleeding, women over 40 years, regardless of endometrial thickness. Women under 40 years with endometrial thickness exceeding 15 millimeters. 3. Enlarged uterus, clinically measured at greater than 10 weeks in size, or uterine cavity length exceeding 10 centimeters, often due to fibroids or adenomyosis. 4. Uterine or ovarian pathology identified on ultrasound, such as fibroids or endometriosis. 5. Failure of medical treatment after 6 months of standard therapy, or 6 months on Mirena based on the patient's assessment. 6. Patient request for surgery, such as hysteroscopy or D&C. Surgical treatment. 1. Dilation and curettage, D&C. This is the quickest way to stop bleeding and obtain endometrial sampling. It is the treatment of choice for hypodynamic women. 2. Endometrial ablation, indicated when medical treatment has failed or when medical therapy is contraindicated. 3. Hysterectomy, recommended for failed medical treatment, AUB caused by myomas or abnormal endometrial tissue, and for women who have completed their family. 4. Uterine artery embolization, an option for specific cases. 5. Other surgical options, hysteroscopy with dilation and curettage, polypectomy, myomectomy. Her hemoglobin is 9.6 grams per deciliter. She is started on ferrous fumarate 200 milligrams twice daily, along with tranexamic acid and mefenamic acid. She is not keen on hormonal treatment options. An endometrial biopsy reveals a proliferative endometrium with a shedding pattern and no malignancy changes. After 3 months of treatment, her symptoms remain unchanged. Hysterectomy is discussed, but deemed too radical for her age. Following further discussion, she opts for microwave endometrial ablation. The procedure is successfully performed without complications. Upon review in the clinic, her quality of life shows marked improvement after the procedure. We would like to express our sincere gratitude to Dr. Anuradha Subramaniam and Dr. Vikneswaran Veerasamy for kindly vetting our slides and providing valuable insights. Thank you for watching this presentation on abnormal uterine bleeding. We hope it has been informative and will support you in managing cases effectively in your primary care practice.